Public comment period on this, and there was a public hearing, and so Dr. Barma is going to summarize the results of the public hearing and the department's response to it.
Great, thank you. Thank you very much. So again, to summarize briefly the proposed amendment to Article 181. Article 181 would require that persons obtain written consent from parents before performing direct oral suction of the infant penis as part of the circumcision. We had a period of public comment after the proposed amendment was approved for publication by the board, and there was a public hearing that was held on July 23rd, 2012. We received a total of 21 comments from 18 different sources. 11 of 18 comments were for the amendment, and 7 of 18 comments we received were against the amendment. And we received comments from a number of different sources. These include ritual circumcisers, moelim, ethicists, private citizens, and several religious organizations that are listed here: the International Nurse Association, Agudath Israel of America, and the Central Rabbinical Council of the USA. So we wanted to summarize all of these comments according to the major issues that were raised. Then we will go ahead and present our reaction or response to those comments. And then at the end, discuss some minor changes that have been made to the proposed amendments. So the issues that were raised are summarized here: parental awareness, the evidence supporting the rule, the threshold for when public health action should be taken, ethical considerations, the exercise of religion, freedom of speech, and then the overall effectiveness of the rule. So to address the issue of parental awareness, we received comments from people saying that ultra-Orthodox families in whom this procedure is performed are not sufficiently aware about the risk of direct oral suction. That is, the risk that this procedure can transmit herpes infection. So our response is, in fact, that we agree that unawareness continues even after distribution of a parental educational brochure. We have received complaints over the past several years from families who had this procedure performed as part of circumcision, were not aware that it either would be performed or that it was in fact risky. So this proposed amendment that we have will make parents aware of the risk. The second theme for comments that we received was questioning the evidence supporting this rule. One comment we received was that the department did not consider sources other than moelim when investigating cases of neonatal herpes following direct oral suction. That is, had we considered the role of caregivers in the family, healthcare workers, or other personnel that may have transmitted infection as something other than part of the circumcision. Our response is that the department, in fact, did investigate many possible sources of infection as part of our neonatal herpes investigation. These included interviews with parents, caregivers, and physicians, reviews of inpatient and outpatient medical records, extensive reviews of hospital infection control policies and practices, as well as herpes testing of relevant context when that was actually possible to do. And in all of these investigations, we found, of the 11 cases that we have documented to be confirmed herpes cases, that in fact the likely source of infection, the most highly likely source, not the confirmed source, was in fact the moelim. We also received other comments about our evidence. One was that the data used by the department to estimate the risk of herpes infection following direct oral suction are fundamentally flawed. That we in fact did not show an association between direct oral suction and herpes infection in the newborn. The two major comments regarding this were that we have overstated the number of cases and that we have underestimated the size of the population at risk, which would actually thereby elevate the overall risk associated with neonatal herpes and direct oral suction. We stand firmly by the data, the interpretation, and the conclusions. They have been published by the Centers for Disease Control in the Morbidity and Mortality Weekly Report, which carefully outlines the data, the justifications, and the calculations, and show quite clearly that there is a more than threefold increased risk of contracting neonatal herpes in infant males that undergo direct oral suction as part of circumcision. We also received a comment from a mathematician saying that we should in fact be reporting 99% confidence intervals and not 95% confidence intervals around our risk estimate, and this would thereby increase the imprecision of our estimates and therefore question them. In fact, as I think most people here would recognize, the use of 95% confidence intervals is in fact the standard of practice in all medical research. We also received a comment that DNA evidence is actually needed to prove an association between direct oral suction and neonatal herpes. Our response to this is that obtaining specimens that actually allow DNA comparisons has not been possible. One of the reasons was presented in the previous amendments that we discussed about the inability or difficulty of obtaining specimens. The other challenge we have faced is actually getting cooperation from various people involved in the investigation to actually provide us with specimens sufficient for testing. And we also would make the argument that, as is presented in the published literature, that there are really multiple strong lines of evidence that support an association between direct oral suction and neonatal herpes. And these lines of infection are really quite sufficient for anybody to make the conclusion that there is, in fact, a strong associated risk. We also received comments about our evidence, saying that there is, in fact, no evidence of an association at all between direct oral suction and neonatal herpes infection. As we've mentioned already during this presentation, we've published this data in the CDC's Morbidity and Mortality Report, which clearly describes the increased risk. There have been 3 other papers published in the peer-reviewed literature studying a different population of infants than the one that we described in our publication that shows an association between this practice and neonatal herpes. And there is really a wide body of expert opinion and evidence. The medical literature and herpes experts all conclude that herpes simplex virus biology, epidemiology, transmission, clinical findings all indicate that direct oral contact can transmit herpes to a newborn infant. We also were asked that even if there was data showing an association, whether in fact we have crossed the threshold needed, whether the evidence is really strong enough to take public health action. The comments were basically saying that there's actually controversy in the medical field as to whether herpes simplex virus can in fact be transmitted by direct oral suction during circumcision. And our response is that leaders in the field of infectious diseases, in pediatrics, in public health, all agree that herpes virus can be transmitted during direct oral suction. Various institutions that have either published statements or written letters to the mayor, in fact, include the Centers for Disease Control, the American Academy of Pediatrics, the Infectious Disease Society of America, and the Pediatric Infectious Disease Society of America, all of whom come to the exact same conclusion that we have. And we would also make the point that even if there was some uncertainty, we think that there is sufficient evidence that parents need to be aware about the opinions of experts on this matter. We also received a comment about the ethical considerations. This comment was trying to address the issue that to what extent can a parent in fact consent to having this procedure done on their child, to decide if direct oral suction is in their child's best interests. Some ethicists wrote that a parent must be informed and the choice must in fact be voluntary. So we think that the proposed amendment seeks to assure that parents are in fact informed of the practice and the risk associated with it, and that they agree to the practice before it is performed. One modification that you will see that we will have made to the proposed amendment is that we've removed the term informed consent so that it now simply reads consent, because the document that we are proposing does not contain all of the elements that might be expected in a standard informed consent document, say going for an elective surgical procedure. We also received comments that we are, by making this proposed amendment, somehow impeding the exercise of religion. Our response is that freedom to exercise religion is not in fact absolute. In 1944, a U.S. Supreme Court noted, in fact, that the right to practice religion freely does not include the right to expose the community or the child to communicable disease or the latter to ill health or death. And we have presented substantial evidence showing, in fact, that neonatal herpes is in fact associated with severe illness and, in 2 situations, death. We also feel that our rule is narrowly tailored. It does not prohibit either ritual circumcision or direct oral suction. We also received legal concerns that we were imposing, that we were restricting freedom of speech. That in fact the amendment interferes with freedom of speech specifically because we are asking Moyalim to be forced to express beliefs that are not in fact their own. Our response is that the amendment is now going to be modified to require that the consent form state clearly that it is the department's position that the procedure is risky. We also received general comments questioning the effectiveness of the rule. Some people, in fact, felt very strongly that direct oral suction should be banned, and that the proposed amendment does not, in fact, go far enough in protecting the health of infants. Our response is that the department is really seeking the most narrow approach possible to fulfill its mandate, while not impeding the practice of religious practice. We recognize strongly that there is, in fact, a recognition, broadly accepted, that circumcision is both a medical practice as well as a religious practice. And so we need to narrowly tailor our regulation to balance those two interests. One comment that we received was from a person who said that he was a practicing mohel, and that in fact he might in fact discontinue oral suction if the rule was passed, because he recognizes that a lot of family members, a lot of parents, would not consent to it. We received a number of other comments that I've listed up here that were fairly specific. They were related to recommendations about the process of parental consent. One comment was regarding about the need to make sure that consent is provided in advance of the day when the procedure is performed. A requirement that, in fact, both parents, not just one parent, actually sign the document. That the person performing circumcision should actually retain copies of that document for up to 3 years, as opposed to up to 1 year, which is what we had originally proposed. And that some people felt that the consent form should actually be filed and maintained by the department. Regarding obtaining the consent in advance, we agree with that. We think that requiring both parents to sign is often impractical, particularly in situations where only one parent is the primary caregiver. We feel that 1 year should be adequate for the purposes of education and potentially for assessing compliance if that ever becomes necessary. And that our primary objective is education. It's not going to be focused on verification and enforcement. We also received comments that there was no basis for mentioning the possible transmission of other pathogens, which was originally included in the original proposed parental consent. The document referred to both herpes as well as other pathogens being transmitted. The department does have evidence of at least 3 reports of serious bacterial infection that have been transmitted following direct oral suction. And there is an ample historical medical literature documenting the transmission of tuberculosis and syphilis and other infectious diseases. But in this situation, because our primary risk is herpes simplex infection, that is the infection that we're trying to prevent, we have modified and removed this phrase from our consent language. So I'll now summarize then the changes that we are proposing to the original amendment that was published. Some of these are in response to the comments that we received, and some of them are after further consideration and deliberation within the department. So we have removed and deleted the word informed from the description of consent, so that it now only refers to the term consent. We have made a clarification so that only the circumciser, not the parents, is the one that's responsible for retaining a copy of the consent form. We have removed any reference to transmission of other pathogens. We have also made a clarification so that the definition of direct oral suction has now been amended to indicate that this actually refers to the mouth of the person performing or assisting circumcision, because there have been situations in which direct oral suction is done by somebody other than the person who actually makes the incision, who actually performs the cut. We have also modified the amendment so that additional elements are now specified for inclusion on the consent form, and these are now listed here. And this provides specific pieces of information that can be independently ascertained if the department needs to follow up on complaints that consent was in fact not obtained. Additional changes include, it allows as I mentioned, we now allow the use of a form other than the one developed by the department. This was in response to the concern that was raised about impeding free exercise of speech or imposing our speech upon somebody else. But we are very clear in the amendment that we specify language that must be included in any consent form other than one that is used by the department. The form specifically will be labeled consent to perform direct oral suction during circumcision, and it will include some specific elements, as we mentioned before, specific data that is needed. And then it shall include a statement, and I'll read the statement here. The statement reads, I understand that direct oral suction will be performed on my child, and that the New York City Department of Health and Mental Hygiene advises parents that direct oral suction should not be performed because it exposes an infant to the risk of transmission of herpes simplex virus infection, which may result in brain damage or death. So that's the end of our review of the comments and our response to those comments.
Okay, thank you very much. I'll go up to the board now for questions for Dr. Varma. Let me start on this side this time. Dr. Klitzman, then we'll work our way around.
Thank you. Are you aware of other jurisdictions that have addressed this issue? And could you, if so, can you tell us how they've addressed it?
We are not aware of any jurisdictions that have addressed this issue. This has been an issue that has been largely detected within New York City, I think primarily because, number one, there's a very large concentration of Orthodox Jewish people that use this practice during circumcision. And number two, we have an enhanced infectious disease surveillance system here. There have been cases that we have been reported, both in the literature as well as through reports that we have received in other counties in New York City, and other counties in New York State, so upstate New York, in New Jersey, and in Israel. And California as well too, no, just Israel, just New Jersey, upstate New York City, Canada, and Israel. But we don't know of anybody who's actually imposed any modifications or changes to their laws as a result of this. So there has been,
we have seen reports and have had communications from Israeli public health colleagues that the Israel Ambulatory Pediatrics Association has been lobbying the Ministry of Health around this issue and has made statements regarding the danger of this practice in terms of herpes transmission and the wish that parents be educated on this before they leave the hospital on the risks.
I want to thank you for your very clear presentation. This might have come up in our last meeting, but I wanted to bring it up just to refresh my memory and just kind of be clear about this. My understanding is a good number of the practitioners who are performing this procedure are not in any kind of registry. We don't necessarily know who the practitioners are. So first question is, what is your strategy on finding out who those folks are and getting the information to them, and how will you actually get the documents to them and have that conversation?
There is extensive awareness among the community that's affected by this, specifically the rabbis in Moylim that are involved in this, and knowledge about our attempts to educate the community widely. So I don't think that there's any a lack of awareness among the people performing circumcision. We think there's a lack of awareness among the families who are having circumcision performed. So we think they'll be quite aware of the regulations that will go into effect. Our strategy will be to, in fact, try to work with these organizations to make sure that they have consent forms that we will provide. These will certainly be available both by the internet as well as printed copies that we can make available to people that request it. And then, of course, we would encourage people that if they choose to develop their own consent forms to do so, but in fact to require that they include this required necessary elements.
My second question is, my understanding is this is primarily an educational initiative, and that if you find that a particular Moylim is not in adherence with the recommendations, that there are no repercussions. Is that correct?
We are not stating ahead of time what our plan will be for enforcement, because as with any violations of the health code, there are always extenuating circumstances, and so the enforcement that the penalty that could be imposed is not mandated by the health code itself. What the health code authorizes us to do is everything from further education of the person who has violated the health code to issuance of a warning letter, such that if you continue to violate this health code violation, further restrictions will occur, and then a monetary fine. And the monetary fine can range in quantities up to a maximum of about $2,000. And Tom Narrell can correct me if there's a problem with what I've summarized. So we would certainly be involved in reviewing consent forms in situations in which the family members of the public complain that somebody has not in fact obtained consent, because that would be an obligation for us to respond to that public complaint. And I think also as part of a neonatal herpes investigation, We would also like to see if there was a consent form provided if in fact there was a suspicion that transmission occurred as part of a direct oral touch.
Thank you. Questions on this side, questions on this side. Dr. Foreman. Oh, I'm sorry. Dr. Goulet and then Dr. Foreman.
Thank you. I want to commend you and the department for taking this on. I realize it's a tricky issue. I suppose I come at this from the point of the comment that you got about why we're not going further, but I understand it's politically sensitive. So let me just ask a slightly parallel question. Is there any equivalent where we are asking parents to consent to having their neonate undergo a potential life-threatening procedure that is absolutely not medically necessary?
Not that I'm aware of. I don't know, Tom or Ross, do you think of anything? No.
So, having said that, and as anybody who's consented in a patient in hospital context or in care context knows, there are ways of consenting and ways of consenting. What's your plan to ensure that the consent, which I understand is largely an educational tool, is actually done properly, respecting the spirit of what you're trying to achieve?
It's a very difficult question. I think it is impractical for us to be actually monitoring circumcisions to make sure the consent is performed adequately. So I think that our efforts to investigate and enforce would be based upon the two situations that I mentioned before. One would be in a situation, in fact, where we receive a complaint from the public, as we have in the past, that this procedure was performed as part of circumcision and the parent was unaware of it, or the other situation in which neonatal herpes is transmitted. But I don't think it's practical for us to prospectively enforce or mandate the manner in which that consent is actually going to occur.
Yeah, I sort of thought a lot about this and read the material. At the end of the day, I'm in favor of it. It makes me uneasy because I feel like we are essentially trying to regulate around the margins when it's something that where the evidence is so abundantly clear. But I respect the line I'm trying to walk here.
Dr. Foreman.
Thank you. I just want to reiterate or agree with Dr. Galea, and I have the same concerns, and particularly around the issue of consent. I think the proposal says that it's obtained prior to circumcision, but doesn't say anything else about when and how. And obviously in the religious practice of circumcision, it's usually 8 days of age, so there is an opportunity. But that's my concern. I will reiterate what I said at the last meeting, which is I have a picture in my mind of somebody being at the time of the circumcision being asked to sign a piece of paper, and that the actual education will not be adequate. And even if it is, the true ability of the parents to opt out will be very limited. In fact, there was a comment submitted about this about a mother, I think, who said she never looked, never knew this was going on. I think those circumstances are very difficult, and I would hope that the opportunity after birth in the hospital before discharge is a good time. The second, I don't know, again, I would argue strongly for something a little stronger, because again, I agree that the evidence to me is overwhelming. This is a life-threatening disorder. Having seen at least one case myself in our hospital in the past few years, it's crazy that we allow this to go on, I think. So I really wish we did something stronger. The second is, in terms of information and who the practitioners are, is there any attempt to figure out a way to help provide families with an ability to discriminate between different moiline? In other words, how do I know as a parent how to choose? So even if I am informed in advance, and I know that some do and some don't, how do I figure out who does and who doesn't?
No, thank you for your comments, and we certainly share the concerns that have been expressed by the board regarding, and that were expressed in the public comment period about whether, in fact, we should go further than what we have proposed. I think, as I mentioned before, and I'll reiterate, we are in a very difficult legal situation because we are dealing with a practice that is both legally recognized as a medical practice as well as a religious practice. And anything that we do that involves, that can be perceived as regulation of religious practice needs to have a very clear public necessity, which I think we've clearly demonstrated, but also needs to be narrowly tailored so that it doesn't excessively restrict the practice of religion. So that's where we've landed and left ourselves. And I think this will certainly continue to be discussed, and we'll have to evaluate over time, prospectively, what the impact of our intervention is. So that's the first issue. The second issue gets to the other one about education. We have gotten the permission of many hospitals in New York City, particularly the hospitals that largely serve this population, to distribute a brochure that we are publishing entitled Before the Bris. It is available both in English as well as in Yiddish, that educates families about this exact issue, and it is meant to be delivered to parents, specifically the mothers and fathers of babies that are born in these hospitals, and that have males and are likely to undergo circumcision. And so we hope that that also is one additional way in which parents are educated and knowledgeable about this. And then the third issue was?
How to advise parents on how to choose a moil.
Oh, how to choose a moil. We're not in that business, so I don't have an answer. Yes.
The situation well enough to know how a parent would discriminate, so I was curious. Can I ask a follow-up question? Can the department mandate the provision of the same information that's in this consent as part of that educational brochure that you just mentioned to, say, all parents of male newborns in the city? Is that within the powers? Because I think that would be more effective at ensuring that the information get to the parents, or some sign that they, or some signature and mandate that the parents sign that they have received that information. Certainly in the hospital setting, we sign lots of things. Yes, I saw this, I saw the HIPAA requirements, whatever. This doesn't seem like a great reach, and I think might be even more effective than requiring the moileen to obtain the consent at a time when I think that there's very little ability of the families to opt out.
Do you want to address this one, Tom? We discussed this issue a lot.
If your question is, could we mandate that this hospitals give out the brochure, the answer is no. The public health law specifically preempts us from regulating locality, from regulating hospitals. It's the states.
Okay, thank you.
And its role in protecting the health of infants, while also being respectful of religious traditions, which we are certainly, we are very supportive of the idea of religious traditions. I think the board members know that we received communications from people who are concerned about this and asked that there be greater dialogue with the department and that this vote be delayed for that greater dialogue. Let me just say that we welcome dialogue around this issue. We think that that's a good thing. We want to work with the community as much as possible. But I also feel that, that delaying this action at this point would be inappropriate, because delaying at this point would be essentially doing nothing, and there is a risk that we may be getting more infections between now and the next meeting. So I think we can take action today while still continuing a dialogue with this community. And if we feel in the future that a different approach is a better approach to this, and based upon those discussions with the community, we can certainly bring that back to the board. Okay, do I hear a motion about this proposal? I hear a motion to approve. Do I hear a second? Second. All in favor of approving this proposal?
Aye.
All opposed? Okay, the motion passes. Thank you very much.